Okay, sir. Bismillahirrahmanirrahim. Assalamu alaikum and good evening to everyone. I'm Dr. Faraz Ahmed and I'm working as a fellow in neonatology at the Indus Hospital. And we have completed our 5 topics on cardiovascular module. And this is our 6th talk. And our today's speaker is Professor Masood Sadiq. Professor Sadiq has recently been appointed as Vice Chancellor, University of Child Health Sciences, Lahore. He Institute of Child Health. He's Professor of Cardiology. After graduating from King Edward, he's trained in UK in pediatric cardiology. He has over 30 years of work experience. He has also been awarded Tamgha Imtiaz by Government of Pakistan and Presidential Gold Medal by President of Pakistan. He has over 100 publications, 80 international presentations as a
Dr. Faraz, I can't hear you anymore.
Sir, his network may be interrupted, and so you can share your screen and we can start presentation.
Thank you very much, Dr. Faraz and Dr. Junaid and the entire team for giving me this opportunity to share our experience of neonatal echocardiography. I was assigned the topic of basics and norms of point of care echocardiography in neonates. I believe the audience is predominantly pediatricians and neonatologists who look after newborns. So that is the focus of the talk as well. When we talk about echocardiography in neonates, functional echo has become now an invaluable tool in the neonatal intensive care units, particularly, but in neonatology in general. And what we call point of care, target or focus ultrasound or echocardiography allows you a bedside cardiac ultrasound evaluation of the hemodynamic status of the patient. It helps in directing treatment, thus improves patient care. And this point of care ultrasound should not be used as a screening tool for diagnosing congenital heart defects in neonates and children. Because unless you're trained as a pediatric echocardiographer, you're not supposed to actually diagnose congenital heart defects.
Excuse me,
because you can make major mistakes.
Dr.
If there's any...
Dr. Sadiq, hi,
Yeah.
Assalamu alaikum, I'm Junaid. Sir, your screen is still not visible, it's not shared.
Oh, sorry. I started. I thought it was being shared. Let me try it again.
It showed some yeah, now it's there.
Now it's there. Should I restart then? Can you see
previously
now
was
clearly?
not there. Excellent. Now, Dr. Sadiq, go ahead. Sorry to interrupt you.
No, not at all. Not at all. No, it's important that the screen is shared. And can you see it now?
Excellent. Yes, now it's good.
Okay. I will restart. I think. Thank you very much once again. I will be talking about basics and norms of point of care echocardiography in neonates. When we talk about echocardiography in neonates, I think the functional echo has become an invaluable tool in the neonatal intensive care in particular and neonatal units in general. And this, what we call point of care, target or focused ultrasound echocardiography, allows you bedside ultrasound evaluation of the hemodynamic status of the patient and helps you in directing treatment, hence improves your patient care. But I think there is a big word of caution here. This should not be used as a screening tool for diagnosing congenital heart defects in neonates, because you can miss a major diagnosis. And unless you are a trained pediatric echocardiographer, you're not supposed to actually diagnose congenital heart defect by point of care ultrasound. And if any structural abnormality is suspected or diagnosed, then of course a formal echo should be performed by a pediatric cardiologist. Because my audience is going to be neonatologists and pediatricians, I thought I will start from the very basic. We all know what echo means. It's something you experience all the time. If you shout into a well, the echo comes back a moment later. And the echo occurs because some of the sound waves in your shout reflect off a surface, which is either water or bottom of the well or wall on the far side of the well, and it travels back to your ears. And this is exactly the principle which applies to cardiac ultrasound. Echocardiography uses ultrasound technology to obtain images of the heart and vascular structures. And these ultrasounds are sound frequencies which are higher than audible range of 20,000 cycles per second. So the ultrasound machine consists of a central processor, a transducer, which can convert a mechanical energy from electrical energy and vice versa through piezoelectric crystals within the transducer. And I will sort of show you a couple of further slides on this basic concept of echocardiography, because it's a type of ultrasound that uses high-pitched sound waves to produce an image of the heart. And these sound waves are sent through a device, which we call a transducer, and are reflected off the various structures of the heart or vessels. And these echoes are then converted into pictures of the heart and vessels, which can be seen on a video monitor. And the greatest thing about echocardiography is you do not need any special preparation. It's a bedside test which can be done at any time. Now, what happens is that this ultrasound gel, which is applied to the transducer, it allows transmission of sound waves from the transducer to the skin, and then transducer transforms this mechanical energy into an electrical signal, which is then processed by the computer and displayed as an image on the screen, as you can see over here. And this conversion of sound to electrical energy is what we call the piezoelectric effect. So this is the fundamental or basic of echocardiography or ultrasound, which we use in pediatric or neonatal age group. Now, if you look at any computer sort of echocardiography computer, you can see it has a transducer, it has a keyboard, a onboard computer, a monitor, a pulse control, and then of course a CD or DVD drive. But nowadays you can actually have other modes of actually saving these images as well. So what are the types of echocardiography which we use in clinical practice? Of course, we use transthoracic, transesophageal, intracardiac, and stress echo. But I think the topic today will be restricted to transthoracic echo, because that's what we use for point of care echocardiography in neonatal units. So coming back to transthoracic echocardiogram, there are three fundamental parts, or you can say types of echocardiography which we do. The first one is what we call two-dimensional echocardiography. This is the normal picture of the heart which you see on an echo screen, and that shows you the structure and function of the heart. The second part or the component is what we call M-mode echocardiography, which evaluates the cardiac dimensions, timing with the cardiac cycle and function, and is best obtained by either parasternal long or short axis. And we will be coming to that in a moment. And then Doppler echo. Of course, Doppler technology allows determination of speed and direction of blood flow by utilizing the Doppler effect. And you can see there are two fundamental types. One, which we call pulsed wave Doppler, which uses a single crystal, so it can only measure low velocity jets. And then the continuous wave Doppler, which uses two crystals, and this is a continuous transmission and reception, and this can actually be used for high velocity Dopplers. And of course, then the color wave Doppler, which uses the same principle as well. So why do we need to do an echo in a newborn? I think we're all well aware of these fundamental indications of doing an echocardiogram in a newborn. Neonates with cyanosis, neonates with heart failure, shock, any audible heart murmur, poor or absent femoral pulses, suspected pericardial effusion. If you put in a central line and you want to see the central line placement, both in terms of position as well as procedure, suspected duct, especially in a preterm baby, and persistent pulmonary hypertension of the newborn. I've restricted these indications. Of course, you can expand upon these as well, because there are many other conditions where you would be actually using echocardiography. But these are the fundamentals where actually you use echocardiography as an indication in a neonate. What do we mean by targeted or functional echocardiography? Let's be very clear about that. I think the indications of targeted or functional or point of care echocardiography are different. It is to assess cardiac filling, or what we call preload assessment and intravascular volume status in a intensive care, to assess fluid responsiveness in a neonate, semi-quantitative assessment of cardiac function. This is one of the most important reasons why we use echo or point of care echo in neonatology. Similarly, measurement of pulmonary artery systolic pressure in assessment of pulmonary hypertension. Again, one of the most important fundamentals in a neonatal echocardiogram, both structural and functional assessment. Semi-quantitative assessment of pulmonary hypertension can also be done to diagnose pericardial effusion, one of the easiest way to diagnose pericardial effusion, and of course then guide pericardiocentesis, to assess the patency of ductus arteriosus, and of course your technique can be guided by ultrasound to put in IV lines, arterial lines, or central lines of any type. And I think these are the fundamental indications why you need point of care targeted or functional echocardiogram. Now, what are the fundamental characteristics of point of care echocardiogram? Well-defined purpose, which obviously is linked to improving care of patients. It's focused and goal-oriented. So you go in there with a clear focus that I want to look at cardiac function. I want to measure pulmonary artery pressure. I want to look for a duct in a preterm baby. I'm suspecting pericardial effusion. I'm putting in a central line, and I'm going there for pericardiocentesis. So it's focused and goal-directed. Findings are easily recognized and easily learned. It is very quickly performed. And of course, the biggest thing is it is performed at the patient's bedside. So what is the technique which we use in pediatric or neonatal echocardiography? One, you must know that what type of probe you should be using. Pediatric echo is done with a probe which is from 4 to 12 megahertz. So as you become smaller and smaller, your megahertz increase. So 12 will be used for a preterm of 1 kilogram, and 4 will be used for a term baby or for a older child. One term which I think if you are going to do an echocardiogram, whether you're a neonatologist or a pediatric cardiologist, one term which you must remember is what we call segmental sequential analysis of the heart. It's very simple, but it's very logical. And what we do is we look at the different segments of the heart in a sequence and analyze them. It's as simple as that. So there are various views that we use: subcostal window, subcostal atrial and four-chamber view, apical four-chamber, parasternal long axis, parasternal short axis, ductal view, and arch view. So what do we do in segmental sequential analysis? First and foremost thing is to see your image orientation, whether you are going to see the heart ups and down or in an anatomical way. Most pediatric cardiologists and neonatologists will see it in a normal way as it appears otherwise. Of course, then you look at the atrial situs and cardiac position, systemic and pulmonary venous connections, atrioventricular and ventricular arterial connections, look at cardiac chambers, atrial septum, ventricular septum, great arteries, their relationship, ductus arteriosus, aortic arch, and of course, acquired abnormalities like pericardial effusion or vegetations. And I will go through them one by one because this is the most important aspect of echocardiography. Now, the first thing is atrial situs. Now, what we mean by atrial situs is that the God Almighty has made heart in a logical way. You have a right heart and a left heart. Your right atrium is of a certain morphology, and your right ventricle is also of a certain morphology. So is your right tricuspid valve and pulmonary valve. So your right atrium is morphologically different from left atrium, and your right ventricle is morphologically different from left ventricle. When we say situs solitus, it means all the structures of the heart are its normal position. So the heart is in the left hemithorax, Right atrium is connected to right ventricle through tricuspid valve, and then that is connected to the pulmonary artery. And similarly, your left atrium is on the left side and your right atrium is on the right side. The way you look at it on ultrasound is very simple. You go on your subcostal window and you look at the IVC and aorta. Now, on the screen, this is your IVC and this is your aorta, and this is your liver. And you can see hepatic veins over there. So your IVC is on the right and your aorta is on the left. But in terms of screen, IVC will be on the left of the screen. If it is on the right and aorta is on the left, we call it situs solitus or normal situs. And when the whole thing is reversed, as you can see on the left, on the right, left of your screen, then your IVC is on the left side, your aorta is on the right side. We call it situs inversus. Now, 99% of the people would have either situs solitus or rarely situs inversus, but 1% will have what we call situs ambiguous. But I think that's beyond the scope of this talk, because getting into that will confuse you even further. When we say situs ambiguous, we mean right atrial isomerism and left atrial isomerism. I think that should be left to the pediatric cardiologist. Location of the heart. Is the heart on the left chest, in the right chest, or in the middle? If it's in the left chest, it's levocardia. If it's in the right chest, apex facing to the right, it's dextrocardia. If it's in the middle, it's mesocardia. And of course, you can have ectopia cordis as well, which each one of you knows means that the heart is actually not lying within the thoracic cavity, it's outside. Once you have made sure that the heart is in its correct position and the situs is either situs solitus or situs inversus, then you need to look at the veins. And the two most important veins in clinical practice are what we call IVC and SVC. IVC connects to the right atrium on the bottom, and SVC connects to the right atrium at the top. So when we say normal systemic connections, we mean both veins are connected correctly to the right atrium. So this is called normal systemic venous connection. Similarly, you need to look at the pulmonary veins and make sure that all pulmonary veins are connected to the left atrium. You can see that on 2D, you can see that on color, both in 4-chamber or subcostal windows. And you need to make sure that on color you demonstrate pulmonary venous flow coming into the left atrium. If the pulmonary veins are connected to the left atrium, it's normal pulmonary venous connection. Then you move on to 4-chamber view. And when we say 4-chamber view, what we mean by looking at that is you look at the AV concordance, interventricular septum, and AV valves. AV means atrioventricular. So AV valves are tricuspid valve and mitral valve. This is your interatrial septum, and this is your interventricular septum. So you look at whether there is any interatrial communication, interventricular communication, and of course, you look at both sizes and functions of your atria and ventricles. And you will learn with time how to look at the function, and I will be coming to that in a moment. But if your right atrium is connected to right ventricle, it is AV concordance. If your left atrium is connected to left ventricle, it is AV concordance. Similarly, you need to look at the interatrial septum, as I said earlier, interventricular septum, and of course, you need to look at both the atria and the ventricles. Then comes the parasternal long axis view. Over here, what you are seeing, this is left ventricle, left atrium, mitral valve, aortic valve, aorta, and this is your right ventricle. So what you see here is whether mitral valve is normal or not, whether aortic valve is normal or not, and is there a mitral aortic continuity, and your left ventricle is connected to aorta. So if your left ventricle is connected to aorta, it's called ventriculo-arterial concordance. And of course, you look at the interventricular septum in this view as well to make sure that it is intact and there is no ventricular septal defect. Now look at this patient and compare it with the previous one. What you can see over here is that your actually left ventricle is connected to pulmonary artery and your right ventricle is connected to aorta. So this is a classical transposition of great arteries. Most neonatologists will be able to pick this up because it's very simple and straightforward. If you're not seeing aorta arising from left ventricle, it can only be one thing, and that is transposition of great arteries. Similarly, in short axis view, you need to make this sort of what we call fish mouth. This is your aortic valve, this is your pulmonary valve. And the way it happens is that your aortic valve would always be in the center, forming a fish mouth, and your pulmonary valve would be giving rise to pulmonary artery, which then divides into right and left pulmonary arteries, as you can see over here. And this relationship is called normal relationship. It means ventriculo-arterial concordance. Same here, you can see this is aorta in cross section. This is your pulmonary valve. This is right ventricular outflow tract, tricuspid valve, right atrium. So right atrium connected to tricuspid valve, through the tricuspid valve to right atrium, right ventricle connected to pulmonary artery. It is called atrioventricular and ventriculo-arterial concordance. Now, what is this? Left ventricle is connected to pulmonary artery. So this is called ventriculo-arterial discordance. So the fundamental difference is concordance and discordance. When it occurs other way around, it's called discordance. So once you have defined the relationship of the great arteries, the next thing you do is you look at the PDA or ductal view. So you go slightly upwards from your short axis view. And the moment you do that, you start seeing this, what we call PDA or patent ductus arteriosus. You can see over here in the still image, two nice pictures of the duct. This is pulmonary artery, this is right ventricle, this is aorta, this is descending aorta, and this is PDA. So this is a connection between descending aorta and pulmonary artery. Arch view, you can see a very nice arch view from the suprasternal view. You need to make sure there is no coarctation, and you also need to make sure that all the head and neck vessels are arising from the ascending aorta or aortic arch. As you can see, innominate artery, left common carotid, left subclavian artery, all arising from the aortic arch, and this is your ascending aorta. Now, once you have done a segmental sequential analysis of the heart, then we come to the focused echocardiography, what we call point of care echocardiography. And the first thing, and the first and foremost thing which we look at in that is what we call cardiac filling. Now, cardiac filling is seen most predominantly either by looking at the chamber sizes. So you look at right atrium, right ventricle, is it underfilled or overfilled? Similarly, you look at left atrium, left ventricle, whether it's underfilled or overfilled. It will take a while for you to understand what is underfilling and what is overfilling. So there's no match to experience. If I show you one picture, you're not going to make out whether that's underfilled or overfilled. But I think one of the important things in particularly non-ventilated babies is to look at the IVC. You need to look at the collapsibility of the IVC. A dilated IVC with decreased collapsibility is a sign of increased right atrial pressure. And that's why you look at the cardiac filling, whether that's appropriate or not, and whether you should be giving volume or you should be putting this child on inotropes. Does he need more volume or does he need inotropic support? I think this is a fundamental question which you keep on asking yourself as a neonatologist or as an intensivist. On the contrary, if this IVC, which you are seeing over here, is totally collapsed, it will indicate hypovolemia. The one important thing to remember is if you have an umbilical central catheter, that can obviously D-shape this, and you will not be able to make a clear judgment on that. The second point of care or focused echocardiography principle is looking at fluid responsiveness. Now, I must warn you on fluid responsiveness because that's something which you really need to be fairly experienced. In the beginning, this is not something you will be able to pick up or make out because it requires doing a pulse wave Doppler in 5-chamber view of the heart. You can see the 5-chamber view of the heart over here. This is your left ventricle, right ventricle. This is the aortic valve. So under the aortic valve, you do a pulse wave Doppler, and that gives you a velocity time interval or integral. They're named both ways. And a variation of more than 15% has been reported as a very high predictive value with a sensitivity or specificity exceeding 90%. So if you're good at doing it, then you will make an excellent assessment in terms of sort of neonatal. As you can see over here, this is normal VTI. And this is a patient who is in a cardiogenic shock, and this is a patient who is in a septic shock. And you can really make out from this very easily if you are experienced echocardiographer. Now, this is something which even a beginner should be able to do. And that is looking at the myocardial function, what we call eyeballing effect. So you just look at the heart and see whether the heart is contracting or not. And if you see that the heart is very well contracting, then your myocardial function is okay. You don't need to measure the ejection fraction, fractional shortening, because that you need to learn how to do it. And similarly, if your heart looks dilated and if it is hardly contracting or minimally contracting, you will be able to make out. And in the beginning, what you need to do is look at different views. Look at four-chamber, look at parasternal long axis, look at short axis, look at subcostal, so that you can be confident that you are looking at the myocardium and the heart function is compromised or is normal or is supranormal. You will be able to actually detect that by just looking at the heart, what we call eyeballing assessment of a neonatologist or a cardiologist. Of course, experience, there's no shortcut to experience. And once you become more experienced, you will be able to learn that very quickly. Once you have learned that, obviously the best way of assessment of myocardial function is actually measuring the ejection fraction and fractional shortening. And we all know that your ejection fraction is normally 68 to 84%, and your fractional shortening is between 28 and 44%. And once you get an M mode of the myocardium, then you need to measure the diastolic dimension and the systolic dimension. And the machine automatically will calculate the ejection fraction and fractional shortening for you. But what is important is that your M mode cursor is at correct position and you are aligned correctly in a parasternal long axis or a parasternal short axis view. Now that is what requires experience. That's why we say that measurement of ejection fraction and fraction shortening will fall in advanced echocardiography training, which I think this day and age a neonatologist should acquire. Pulmonary hypertension. This is a question which you keep on asking all the time in these newborns. Meconium aspiration, structural heart disease, birth asphyxia, and so on. And assessment of pulmonary artery systolic pressure in pulmonary hypertension in neonates is one of the fundamental things which you can do. And I think the best way of doing it is measuring tricuspid regurgitation jet. So you need to align your continuous wave Doppler to the TR jet and then measure the tricuspid regurgitation jet. As you can see over here, TR max is 5.12, and the machine would automatically calculate the tricuspid regurgitation maximum gradient by using what we call modified Bernoulli equation. And in the absence of right ventricular outflow tract obstruction, this regurgitant velocity represents the difference in pressure between right atrium and right ventricle. So if you're going to measure the pulmonary artery pressure, you need to add right atrial pressure into that. So say your TR jet is 104, your right atrial pressure is 10, your PA pressure in the absence of pulmonary stenosis will be 114 millimeters of mercury. So persistent pulmonary hypertension, there are other ways which are more softer but very reliable ways of actually making sure that you're picking up pulmonary hypertension. And you can, of course, the best way is to measure the tricuspid regurgitation, but you don't always get tricuspid regurgitation. So there are other things. Look at the intraatrial septum. If your intraatrial septum is bowing to the left, you are dealing with pulmonary hypertension. Look at intraatrial septum, interventricular septum. If your interventricular septum is bowing to the left with a dilated right ventricle, it is pulmonary hypertension. If your right atrium and right ventricle are dilated, you're probably dealing with pulmonary hypertension. And very importantly, if you can see the direction of flow in both PFO and PDA, and it's either bidirectional or right to left, you're dealing with pulmonary hypertension. Look at this Doppler over here. You can see both blue and red coming across the PFO. This is your SVC, this is your right atrium, this is your left atrium. So bidirectional shunt means your pressures in both RA and LA are equal. So atrial shunting is an extremely important thing to look at, because this can not only point towards pulmonary hypertension, but it also gives you an indication of a possible structural heart disease. So if you see a left to right shunt across the duct, this is normal. Across the PFO, this is normal. But if you see right to left, or if you see your interatrial septum bowing to the left, then you should suspect either persistent pulmonary hypertension of the newborn or a structural heart disease like total anomalous pulmonary venous drainage. So bowing of interatrial septum and right to left shunt should be looked at very carefully. Ask your pediatric cardiologist to have a look. Ductal shunting. I think the duct is one of the very important things which we see in clinical practice, particularly in newborns. And of course, we know that ductal shunting is a consequence of increase in systemic vascular resistance and a decrease in pulmonary vascular resistance. It is more important in early hours of birth or in children who are preterm. And I think measurements of ductal diameter, looking at flow from left to right or right to left, measuring left atrial and aortic ratio, seeing whether there is a diastolic flow in left pulmonary artery or in descending aorta, all are fundamentals of looking at the size of PDA. And this is again something which you need to learn, but a point of care echocardiography includes assessment of a duct. So look at this patient over here. If you look at the right, this is a very large PDA, which is shunting left to right. This is your dilated right pulmonary artery, dilated main pulmonary artery, and look at a very large PDA shunting left to right at the ductal level. On the contrary, if you look at here, this is a very small PDA, which is shunting left to right in a patient who has a small duct. Similarly, you can do a Doppler across the duct, and you can see a continuous wave Doppler being shown here in a patient with a small duct and a large duct. In large duct, your diastolic flow tends to return to normal or to the zero level. Very importantly, pericardial effusion. I think this point of care ultrasound is extremely helpful in diagnosing pericardial effusion. And every neonatologist and a pediatrician working in an intensive care unit must be able to pick up pericardial effusion. Look at this heart. You can see a large pericardial effusion all around the heart. Now, two important things about pericardial effusion. One, you must see it in more than one view. So you should see it in four-chamber as well as subcostal view. If you're only seeing it in one view, you should be questioning whether you're dealing with something else. Is it something outside the pericardium which you are looking at? Because pleural effusions, sometimes large tumors, can easily be confused with pericardial effusion. And second, I think cardiac tamponade should be picked up. You should be able to see whether the child is tamponading or not. And the best way to see tamponade is looking at the right atrial wall. If you see non-expensile right atrial wall and echo, this is an impending sign of pericardial tamponade, and these patients need pericardiocentesis immediately. Looking at vegetations or endocarditis is really not point of care echocardiography. This is something which a pediatric cardiologist needs to look at. But I think what is important now is that as more and more newborns are now having central lines, umbilical catheters, arterial lines, and they are potential focus for vegetation, it is important that a neonatologist is trained to look at a potential vegetation or a thrombus. As you can see over here, multiple vegetations in a patient with a PDA which are being shown, and they are hanging about in main pulmonary artery. Of course, this is something which a pediatric cardiologist has to confirm, but a pediatrician or a neonatologist can suspect. I would like to conclude by saying that point of care targeted echocardiography is now a standard of care in any neonatal unit. but it must not be used as a screening tool for diagnosing congenital heart defects. Yes, you can suspect it and ask a pediatric cardiologist to come and make a diagnosis of congenital heart disease. And the goal of cardiac point of care ultrasound is to obtain physiological and hemodynamic information which aids you in clinical decision making in any pediatric, neonatal, or intensive care setting. And the neonatologist must understand and be trained in the fundamental basics of echocardiography. If any structural abnormality is suspected or diagnosed while performing targeted echo, a formal echocardiogram must be performed.
Sorry for interruption. Dr. Masood having some network problem. So as he is joining, we will resume shortly. He is joined and we are resuming.
Okay, Dr. Masood, can you unmute yourself?
Okay, hello.
Dr. Masood, yeah.
We lost electricity. Actually, there was a power failure again, but
No
fortunately,
problem, no problem.
we get
So,
the last slide. So
sure.
I hope we were able to. I can go back on the last slide if you wish. So by concluding by saying that if there is any structural abnormality which is suspected or diagnosed when performing a targeted echo, I think you need a formal echocardiogram from a pediatric cardiologist. I would like to thank my senior registrar, Dr. Gulafshan, who helped me in getting echocardiographic images from newborns. And I really thank the organizers for giving me this opportunity to actually be part of this group. And I'm more than happy to answer any questions if there are any.
Professor Saad, Assalamu alaikum. Khalid Haq from California.